Okay. All right. I think we are. Yeah, you're welcome. I think we are on. I hope that you guys were willing to hang in there with me because I've got a great presentation for all of you. I am nestled in the rolling hills of southern Appalachia, and my name is Bill Bauer, and I have been in the field of people with disabilities basically all my life. If you think I sound a little funny, it's because I was born with a severe to profound hearing loss. That severe to profound hearing loss has led me into the world of what I could say is not being the norm. People that know me well know that I'm not within the norm to begin with. But I do want to say thank you for having me here and thank you for being patient. And I hope I can go a little bit overboard because I have so much information to share with you. Okay, now I have worked with people with developmental disabilities for a long time. I was a swimming instructor to begin with. I became a school teacher of children with orthopedic impairment. And it's funny now because as being a school teacher, I see some of the consumers through this great organization called RHDD. I see them as older adults. And it's so neat to see their life progress to where they are now. And that's been a blessing for me to see them as they grow developmentally, mentally, socially, and so forth. But today I'm going to talk about you as a DSP, a provider, talk about your providees, which happens to be your clients. And I am so sure that many of your consumers, many of your clients consider you as a family member. I know I've worked with people with disabilities for years. I've worked with many DSP providers. And I know for sure that when it comes to family, the DSP providers generally are in that inner category of national support system. So, in order for the national support system to be socially, emotionally healthy, we've got to have training for both the providers, the provider agencies, and people with disabilities and people with intellectual disabilities. So I'm going to zoom through these. If everybody could go to the chat and just say, I can hear you, I can see you, that's going to be confidence for me. And we're going to go ahead and get started. If you can do that, I would really appreciate it. Another thing, if you could also get a piece of paper and a pencil and get ready, because we are going to use your fine motor skills. Sonia, I can see and hear you. Shelly, I can see and hear you. I'm 100% good now. When somebody says I'm 100%, I can't even imagine what they mean. So, Amanda, good to see you. And you can see the presentation. So let's move on. Lisa, if you're there, hi. I'm just so grateful to be able to be on this virtually for you. So, what do we know? We know that mental health problems are common. We do know that there is a stigmatism associated with people with mental health issues. Not only do we know that people have mental health issues, we do know that we do have a population that simply doesn't want to talk about it. And throughout all of my life and advocating for people with disabilities, being quiet, being silent can kill. It is so important that people with disabilities have the voice to say, you know what? I am getting my physical needs taken care of. But you know what? There's another part of me that needs care of too, and that is my mental health. People, especially people who are not in the field of mental health, are not very well informed. They don't know about the neurotransmitters, which you're going to know about today. They don't also know about the impact of how mental illness, and if you're nonverbal, the impact, if you're nonverbal, how do I tell you that I'm depressed? If I can't talk and I haven't talked for years, how can I tell and show you that I have anxiety? Do I show signs of panic and you just think I'm upset? Do I show signs of anxiety and we just take it as, oh, that's just them? Many years, people with disabilities were told to go, where to live, who to live with, what clothes to wear, what food to eat, who they could associate with and who they couldn't. Now, as we take our, hi Jill, as we take our lives in general, imagine every day getting up. Somebody, now this was years ago, somebody telling you what you want to, what you have to wear, what you're going to eat, who you're going to talk to, where you have to work, where you're going to go. And there's some of those people may not like going to a place or wearing the same clothes or saying things every day. If we do know that, how do they tell us if they can't? Well, we do know that they can tell us a lot of things by their behavior. We do know that. We can tell if they want some avoidance behavior that they may have. So typically every day somebody might do something, but they can't tell you, hey, I really don't want chocolate cake today. You give it to me all the time with my medication. I want peanut butter. So there are a lot of people with intellectual disabilities that are nonverbal. I believe that behavior is trying to show them what and how things are happening. So we do know that professional health is not always on hand. And we do know that personal care, what I could say doctors, we do know that many doctors don't know about intellectual disabilities and mental health conditions. Some things I do want you to know, that any antidepressant, anti-anxiety medicine takes 2 weeks before it works. That's why a doctor would generally say, hey, try this. I'll see you in a couple weeks. An antidepressant or anti-anxiety medicine does not work overnight. It takes at least 2 weeks for it to get into our system. 2 weeks. Now, ADHD medicine, ADD medicine, it will take a day, 24-hour span. But how many of you guys remember back in the olden days, and maybe even now, how many of you guys remember that if you had a child with ADHD, you didn't give them the pill or the ADHD medication on weekends because you wanted to let them loose or have them be more freer? But as a principal and as a teacher, I can tell you one thing. If we know ADD medicine and ADHD medicine take 24 hours for it to work, and they don't give it to them on the weekend, but they do give it to them Monday morning, what's the worst day for educators and DSP providers if they don't get their ADD medicine and ADHD medicine on the weekend? Monday. Many people have come to me and said, well, they must have had a bad day or bad weekend at their dad's house. They must have had a bad weekend at their mom's house. But the problem with ADHD and ADD medicine is it's a 24-hour span before it kicks in. You also have to know that when psychotropics or medication that you take for depression and anxiety, we do know that it takes 2 weeks, but sometimes doctors or people will stop taking it before the medication actually gets into their system. So if we're working with people with intellectual disabilities, some of them can't say, oh, I feel good or oh, I feel bad. We are just assuming that if it doesn't work after 4 or 5 days, we call the doctor and take this off of them. 2 weeks. Now, a lot can happen in those 2 weeks. There could be side effects where anxiety could increase. If anxiety increases, you just got to keep an eye on it to see if it will decrease within the 2 weeks. Some people may have had there's several different medications, may have had the wrong medication to begin with, and they're not getting any symptom relief whatsoever. So I do want to let you know that sometimes we've got to look at the medical aspect, and when we look at individuals with intellectual disabilities and ourselves. As many people didn't know that when you take an antidepressant, it's going to be 2 weeks even before it starts again, before it starts to work. Okay. People often don't know how to respond to a person, let alone with an intellectual disability, and a person with a mental health condition combined. That's where training is so important. I'm biased. I'm very biased with the agency that I work with in Southeastern Ohio. RHDD is a firm believer that mental health is a component of a person's overall picture. And I've done a few presentations for them where I add in the mental health component in addition to the intellectual disability developmentally delayed component. And we can look at the total picture here of what a consumer might understand and maybe what the DSP thought they knew or thought they were doing correct. People with mental health problems do not seek help. This is why I really need to point this out. If consumers have mental health issues, and let's add the nonverbal component, by golly, they need you. They need you, and the longer that you've known them, they need you even more. Too many people with disabilities, developmental disabilities that may have been nonverbal or intellectually delayed may have a history of poor treatment. When they were a child, they can't tell you if they were abused, neglected. Some of them can't even tell you how they feel, but they can certainly show you. So it's very important that when we look at a person with a developmental delay, that we look at the history. Some of them may be still thinking about post-traumatic stress of perhaps maybe when a teacher used to just maybe hit them with a ruler, or post-traumatic stress when something happened at the home. Now, we as individuals that can speak can talk about it. We can go to a counselor. We can do, and some people do self-medication, which is not good. We can do those things, but a person with a disability, an intellectual disability, does not have the ability to do that. If we know that post-traumatic stress is something that is important to us as individuals who've had post-trauma, it has to be important for the consumers that we serve. People with disabilities, as far as I'm concerned, the most neglected of all exceptionalities are people with disabilities, and even more so, people with intellectual disabilities. On the forefront, DSP agencies all over the country, all over the state, are putting and making a voice for those consumers. I am so glad because the consumers that I work with, we've empowered them to make choices. We've empowered them to sign to us if they know sign language, to tell us how they feel. We also give them the right to say, today I don't really want to go to the mall. We go to the mall every week, but I would like to go see a movie. So we are giving some self-determination, and boy, is that better than it was in the early 80s before deinstitutionalization came out. So I honestly believe that when a child is born, whether or not with or without a disability, we need to start giving them choices. Because we know people with disabilities over the years have not been given choices. And sometimes it's amazing to see what choices we give them and what they choose. And sometimes students with disabilities have to, for example, me being with a person with a hearing impairment, I used to work at Kentucky Fried Chicken. Now, that was my first job out of high school. And then I went to college and they said, Bill, we don't want you to go to college. And I said, why? We want you to be the head chicken man. I said, what? Me? Be the head chicken man? Yes, Bill, and we will give you 25 cents more an hour. Okay. Went home, told my mom. Mom goes, Bill, no, you're going to go to college. I said, Mom, I don't think you understand this. The head chicken man at Kentucky Fried Chicken goes to the counter. I'm always in the back. So I make the chicken. I know the original recipe, but I've sworn a statement I can't give it out. But the head chicken man goes up front. And they also get to wear those headphone things. Mom, I'm going to do it. Okay, Bill, whatever. So I did it. 6 months, I was the head chicken man at the Kentucky Fried Chicken on the corner of 4th and Green in Marietta, Ohio. So excited. But it was a choice I had to make, whether I wanted to be the head chicken man or go to the route that I am today. So I tried that route first. Well, if you can imagine, the head chicken man at the point would take the orders from the drive-thru. So here I am. Hi, this is Bill from Kentucky Fried Chicken. How may I help you? I acted like I knew what they were saying. Oh, so you want green beans and you want mashed potatoes and you want a 4-piece? Okay, great, thanks. Pull up. Pulled up, got... Many people went around the circle and around the circle because I never gave them what they wanted. I just didn't hear it. So I just knew, as a self-determination, that choice I made, that wasn't good for me. But by golly, there wasn't going to be anybody else to tell me I couldn't be the head chicken man. So sometimes people with disabilities need to make choices and learn from themselves that it may not be the thing for them. But to tell a person with a disability that they can't do something, in my opinion, sets up this barrier of how will I never, ever know if I can't do anything, which leads to a period of self-doubt, a period of maybe leading into depression, or perhaps even worse is what we call learned helplessness, that no matter how hard I try, and I keep trying, and I keep trying, and I keep trying, that I never get to do really what I want to do. So why do I keep trying? With people with disabilities, like all of us, we need to have alternative choices, alternative things to do, to see what we know, and to see what we can do to explore our persona. So people with disabilities are a group of people that, in my opinion, we do not encapsulate things that they can do, and pretty much so, although it's better, we seem to encapsulate what they can't do more than what they can. So with that in mind, we need you, and you know what? As their advocate, DSPs, and as their person who they rely on the most, if not you, then who's going to do it? That's always been my philosophy. If not you, then who? COVID and mental health. Woo! I tell you, it is changing the way we socialize. However, I do want you to know this, that some of our consumers, some of them do, some of our consumers don't get it. They don't know why they're staying in the house. They know that there's this little red germ that's a very powerful germ that could hurt them in some way. We have got to make it so that they, in any way possible, can understand that COVID is something that we all are enduring. Not just them, but all of us are enduring. And that we do have to stay near as much as we can to our original schedule. We know people with autism don't like change, and we know that even some of us don't like change. So what I would like you to do as much as you can, go through a consumer's life and try to do as many natural things as possible, and realize that if something has changed, it may be hard for that consumer. I still see my consumers, my people with intellectual disabilities. I drive out in the country and I meet one person and he sits on the porch and I sit out in the yard. We still laugh and giggle. I'm seeing one person right now in the hospital, which is a different situation at this time. I do see another consumer who is deaf. I see him at his apartment, but I try to make it as natural as I can to what they can and can't do using the social distancing that we have to use as mandated by law. We do know that COVID has given us an increase in anxiety and depression. We also know that COVID has increased stressor-related disorders. Now, I have a private practice. I'm a rehab psychologist. I work with people in trauma. I also work with people with disabilities and I work with your typical people that have depression, anxiety, and unfortunately, I've become an expert somewhat in the field of suicide and prevention and suicide awareness. Unfortunately, my son finished suicide about 5 years ago. Quite a life-changing event for me and my family. My son did work for RHDD, loved it, and I have a unique passion now that no one should ever be in a moment of despair. No one, where they feel like they have nothing to talk to or no one to talk to. We're going to do a little. Skill set here when I get to that part. We do know that we are seeing an increase in substance abuse, and we also see people that are still having sex while they have substance abuse issues. So with that, we may see an increase in kids with fetal alcohol syndrome. We may even see an increase of babies with the families I work with that have developmental delays as a result of them being addicted to heroin or cocaine or LSD when they're born. And then probably one of the most shocking things that I'm seeing in my office now is the increase in suicide ideation or the act of suicide. Unfortunately, I don't know how I got thrust into this position, but it seems that I get a lot of phone calls and a lot of my clients referred to me as a person who could absolutely understand what suicide does and what suicide is all about. But I also understand the stages and so with suicide. So I'm going to go ahead and move to the next slide. Is there functional depression? Functional depression are people that generally they're depressed, but you know what? They go to work every day, they do the same thing, and the cycle happens over and over and over and over. So that's a term that we may have some children and adults that have functional depression, but that's all they know. All they know is to not feel good. And to not feel good, that's what their cycle is. And as we look with people with intellectual disabilities, is this how perhaps maybe some of these young adults and these adults have been feeling all their life, and they've really never had a chance to be relieved of any burden of depression. So here's what depression looks like. Of course, we know it can be somebody who's smiling, but what we do know is what we see on top of the iceberg may not be going on what's underneath. I always work with this philosophy. What I see, and especially in the area of functional behavior assessment, what I see on top of the iceberg may not be really what's going on. So as a DSP and as a friend and a family member, can we really get to a consumer or a workmate or a friend or family member, get to the point of where they can really, really talk to us and let us know what's going on? As a result, being a person that will listen to another person does increase the ability for someone to have a good social relationship, which in turn may lead to that person referring them to a person who might be a counselor, psychiatrist, and so forth. Okay? Remember, that's even in my office. What we see on top of the iceberg may not be going on what's underneath. And I kind of use this scenario with my son Grant. what we saw on the top of the iceberg with Grant, my son, happy-go-lucky, just as fun as I am, or funnier, a person who really liked talking to other people, liked music and so forth. But little did we know that perhaps maybe he was suffering. So when I say the signs and symptoms of suicide are generally there, I'm going to take that word generally, because there are times that they are not seen. And with that, that person is very good at hiding what they feel under here. So, what are signs and symptoms of depression in a subcategory? Here's a whole list. You also have that list. I believe Melissa gave it to you on the website. You have this list here. But I'm not saying that if you have constipation all day, every day, that you have depression. I am just saying that what is here could be a symptom of something deeper. So when I see a consumer with a disability and I see them being angry all the time, if we believe that anger is a behavior, I would have to look at what I think the cause of this is. They can't tell you, but what's happening before? What's the antecedent that causes this behavior? What is the post? What's the consequence of this behavior? So we can't just, as DSPs and providers, we need to make sure that we get the whole picture and not just react to the behavior, such as, stop it, don't do it now. But we need to look at, why is this person doing this? Do they have a history of doing this? Is there a reason they're doing this? I think that so many times we get into this old mode of, let's see here. We react. Stop it, like we do our kids. Stop it. So what we need to do is look at the antecedent, what causes the behavior. That's going to be the really good part. The behavior itself, and then the consequence. Does the person keep doing this because the outcome is what he wants? And that outcome could be a good thing, or it could be a bad thing. All right, so basic neurological fun. I have my handy dandy chart here, and all of you guys are going to get a training on this. I hope I can go past my time, but if I can't, I'm very, very sorry. But I have my chart here all ready for you. And as you see this, what I'm going to do is draw two brain cells. If you've got a brain cell here and a brain cell over here there. We have brain cells. Yep, we do. We've got brain cells. Some of us may not have as many, like me, but anyway, but we have brain cells. If we don't have brain cells and they're not backfiring back and forth, then probably we are brain dead. So, let me tell you how mood disorders work. For example, we all have brain cells, or we wouldn't be sitting here listening to Dr. Bauer. So we all have brain cells. Within those brain cells, we call these neurotransmitters, or neurons. Okay? You guys might see something like this in the old Zoloft commercial. The electrical activity of our brain means that these neurons need to go from one brain cell to the next in order for us to react, to talk, to sit. So if these brain cells aren't moving, then we are practically brain dead. However, we've got these brain cells that are going through an area called a synapse. There's a pre-brain cell synapse, and there's a post-brain cell synapse. So these little neurons are trying to get into this brain cell. Let me show you what happens. If somebody could put on the chart and tell me what is the difference between these circles, and these circles. Can somebody tell me what the difference between the circles are between the cells? Anybody be able to say anything in the chat area what the difference is? The size. Very good, Shelly. The size. Shelly, that's the size. Okay, what I'm here to tell you, these are small, correct? So, if you look at these neurotransmitters cannot backfire, cannot get through this brain cell because these are too small, right? So when one side is heavy, one side is heavy and the other side is small, so one's heavier. I'm going to try to do this with this here. Got all kinds of things ready for you. Going to try to get one side heavier, the other side is lighter. It's not balanced. So this is what we call chemical imbalance. Chemical imbalance. That's what that is. So with that in mind, let's see where my pen went. So with that in mind, we have a chemical imbalance that is working against us. So these are small, biologically and physiologically. This is depression. That is depression. Depression is the neurotransmitters will not follow throughly from one brain cell to the next. You, simply put, you cannot snap out of it. Somebody says, hey, just snap out of it, get out of the bed. If you could, you would. You cannot simply snap out of it. There has to be a way to get out of it. And there's 5 different ways. I hope I'm still on time. 8 minutes, but. All right. One of the ways is prescription drugs. Prescription drugs and talk therapy. So let's just say that I have a depression and the doctor gives me 20 milligrams of Paxil. How long does it take to work? 2 weeks. So within the 2 weeks, we are hoping that this brain cell opening, or this neurotransmitter opening, is going to open so that this will flow more freely. So if it does, if 20 milligrams works, then we know that it's going to flow more freely. Therefore, you start to feel better. However, there are other ways to get this to work. Number 1 is illegal drugs, alcohol, and pot. And I'm just going to give a fast case here because illegal drugs is causing illegal opioids and things like that are causing havoc on the mental health system. For example, this would be heroin, and I'm giving you heroin now. Somebody who's on heroin, the neurological pathways are wider, so therefore the cells are not getting enough. So it's going rapid fire. A person who is addicted to heroin wants to do what? They want to keep these open, right? So in order to keep these open, what do they have to do? They have to keep taking heroin. So what do? They do anything to get it. People with heroin can die on the way up, or they can die of withdrawal, which is happening on the way down. So this is withdrawal. That's another way that they could do it is open these up is exercise. Exercise will open it up a little bit, but after about 20 minutes of exercising, you're like, oh, I don't think I'm going to do it tomorrow. I don't think I'd do it tomorrow. But those who exercise consistently can do this. We just talked a little bit about prescription drugs. And then another thing that seems to be a self-medicator, and I happen to be doing research on this, is screen time, computer, and video games. Watch this. Hey, Mom, I'm home. Okay, son. How's your school? Oh, school was great. Okay, I'll see you later. Great. Kid goes up into his room, plays video games all night, all day. All of a sudden, they're in front of a screen, and think about your consumers as well. They're in front of a screen, right in front of that screen. Guess what? They're in control. I know what ammunition I want to use. I know what ball I'm going to throw and hit Lisa with. Lisa Reed with. I know Shelley Himmersley. I know I'm going to be able to take a monkey and throw it on her and she'll go, ah! So she'll have all of these things. The more time a child is in front of a video game or a video camera, or a video or a camera like that, the more time they're under there, look, they're in control. They're in control of their world. You shut that down, I'm not in control anymore. I have to talk to a person. I have to answer to other people. I have to eat at a particular time. What's happening is we know that the amount of time that young adults, and children, and especially those that have intellectual disabilities, and with the pandemic we're in, we're seeing an increase. We are seeing an increase in the number of kids and adults with social anxiety. That the world is here. Why do I have to go out? I feel so normal. We are also seeing an increase in a subcategory of depression called agoraphobia. I'm so comfortable in my house. I have fear of leaving my house. I don't go out of my house, so I'm okay. And if I go out of my house, I feel a big sense of paranoia. One thing I do want to tell you is that by medical professionals, if a person has any of these mood disorders I was talking to you about, that they must have the symptoms for 2 weeks. Anti-anxiety, antidepressants take at least 2 weeks before they start to work. Remember this, at least 2 weeks. The biggest culprit in all of this is caffeine. I hate it because I love caffeine. But if you are on an antidepressant, what is caffeine? It's a stimulant. Coffee, Red Bull, Mountain Dew, Zero is my favorite, chocolate. If you are an antidepressant to help bring your mood up, caffeine is a stimulant. It's going to take those little circles and make them wider for the period the caffeine is in your system. So look at your clients' behaviors. Do they like caffeine? Do they always have the caffeine? If what's happening is the neurotransmitters are opening. Do they have worse behavior when they have caffeine, any one of these? So you've got to look at that too. Caffeine is a stimulant. It is. It's a just non-medical regulated stimulant. But taking an antipsychotic or anti-anxiety or panic medication will increase the power of it because it is a stimulant. Remember that. Okay. All right. I'm gonna go to the next slide. If everybody would just go ahead and make one of these for me. Get your piece of paper and go ahead and make one of those that's on the screen. I skipped that slide because if I have to skip any, that's the one I want to skip. So go ahead and do this. I promise I'll be done within the next 5 to 10 minutes. So what I would like you to do is go ahead, do that. And then, as you see here, I've got mine, and I'm going to put my name in the middle of it, Bill. Some of you may have seen this before, but not in the way that I'm going to present it to you. So, Bill, in this middle circle, I'm going to put the people that I love, and they love me and care about me the most. So I'm going to put Mary Ella, Maddie, my daughter Maddie. I have a really good friend named Jim. He's really close to me and I'm close to him. Yeah, I'm going to put him in the middle. Then, that's circle number 1. Put as many people as you can in there, put their names only, and put a circle around them. The second one, if I got hurt, I was in the hospital, and these 3 couldn't be there, who would I want? But I don't want them to be there right away, but who would I want to be there if they couldn't be there? So I'm going to put a bunch of names here. Pat, Evan, my sister Bonnie, Randy, Steve. All right, so that's my second tier. My third tier, go ahead and put that first tier, second tier. Go ahead and put people in this. Now, these people are people that are not in your first two tiers, but they're out here, like maybe a coworker. But you may have coworkers that are in here. You may even have a coworker here, but I'll have a coworker here. His name is Joe. I don't want him to come and see me at the hospital, but by golly, if I want a cup of coffee, I can call and text and say, will you bring me one? So Joe, and I have a friend named Lisa. I have a friend named Jen. I got a friend named Jimmy V. I've got Mark. Okay, so these are like, they can be friends, family members. They can be grandparents, cousins, aunts. Oh, I can't forget my teacher who's still living, Miss Weil. I bet I'd like to talk to her. So these are your fourth tier. So in my fourth tier, I've got these people. So what I would like you to do is to take the next 2 to 3 minutes and fill out your natural support system. Just go ahead, fill it out, and I'm going to give you a couple more minutes, and I promise I'll get off quickly, but I want to give you a couple more minutes to get this done. I do have just 2 more slides after this, hopefully that we can get through it, and so once you've done that and you've filled it out, if you could please go to the chat area and tell me how many total people you have in your system. For example, just type in there how many total people, and I'm counting everybody in mine. I have 25 total. So go ahead and just put in the amount of people you have. Count those, and this is so important. I did give you a copy of this in your handouts on this PowerPoint slide because I'm going to tell you what we're going to use it for in a minute, and it will be something definitely that you can use with your consumers, your family, yourself, your home. Lee has 20, Lisa has 17, Julie 12, Andrea 26. Woohoo, Andrea! Wow, keep them coming. So go ahead. Wow, Tracy. Just put in the number of people. Now you may have a little bit more time to do this after I get off here. After I get off here, you may have a little bit more time because you're able to think of your next door neighbors. You probably can't think of them now. You may think about maybe a high school teacher that you could call that's in your fourth tier. You may have a grandma or grandpa or a cousin that you're not really close, but they're in the fourth tier, whatever, so forth. So it looks like we do have some numbers up there. Now, listen to this. Research shows that the more people you have in your first 2 areas, if you have 5, you are socially, emotionally healthy by the fact that you have somebody you can talk to. It doesn't mean that you may not have mental health issues. It doesn't mean that you may have a support system that's not as strong as you think it is. But what it is showing is that these people here and here, by golly, if something happens, who do I call? I've got these. Now, let's put this in perspective. What we need to do is, does your consumers with an intellectual disability have them fill this out? Who do they have? We feel comforted by the fact that we know that if something happens, we have this natural support system to lean on. Do your consumers know this? When they have transitions of staff going all the time, how could they develop a strong bond? So what I would like you to do, if you wanted to take this out, have your DSP just do a natural support system Socio-Gram on the consumers. If you see just mom here, my DSP provider here, and another DSP provider here, would you feel good? What if something happened to mom? If something happened to mom and they were right here and they were gone, the only people that some of these people have is a DSP provider, which is good, but they're not as close. Hopefully we can get them in that inner circle, and a neighbor who used to push him in a swing. So I think that when we look at mental health and mental health issues with people with intellectual disabilities and people with developmental disabilities, we really need to look at the national support system. And for many of us, the national support system are you that's out there. You make a difference in these people's lives. I see it day in and day out with the consumers I work with. When I say, hey, who's your family? Well, it's Heike, it's Johnny, it's Jimmy, it's Ed, it's the... No, that's not your... No, they're my family, Bill. They're my DSPs, and they're my family, Bill. They're mine. I go, oh, okay. Well, what about Dad? Well, he comes something at a time, but my family is da-da, 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 da-da. Remember, they need your support. It's just support. If we can just imagine going home and we only put 3 people in here, we wouldn't feel good. They need to know, and perhaps maybe this, we could just rip it off, hang it up on their refrigerator and say, look how much love is in your life. Look how much support you have. And they go, wow, I've got these many people in my life. Instead of filling it out for us, which we can do, fill it out for them, or have them, if they're nonverbal, who are the people in their life? Fill it out for them. I'm going to move on because I know I don't have enough time. I wish I had another half hour, but the greatest responsibility in your life, and I've always believed this, is to be everything that you can be. Learn. As a DSP, as an administrator, as a person, learn everything you can learn because education is key. And find strength in others, not weaknesses. We know what our weaknesses are. Find out what we can do well. Not only for your own benefit, but for every person's life you will touch. As a first aid responder, as a DSP provider, as a policeman, as a teacher, and there is no greater role in a person's life than to be that person in someone else's life. We can't take everything with us when we die 6 feet under. But what we can toward the end of life is know who cares for us, who we care for, and love always wins. There are some resources here that I left for you. You can look at those. But I just wanted to say thank you, Opera, for allowing me to speak, even though it was a little bit delayed. But I just wanted to thank all of you for allowing me to speak. If you would like to get a hold of me, if you'll go to your site, and your site has on there, the site has my email on it. It has my website. It also has my email. So get on that. You can talk to Lisa Reed. Lisa is a phenomenal person. I think some of you already know that. But if you have anything that I can do for you, let Lisa or email me. But I want to say goodbye and thank you very much.